Today the topic will be to VAD or to transplant. This is the question. And this is an interesting debate of pros and cons for the use of ventricular assist devices or for transplantation of the heart for heart failure. And we have our two terrific speakers today with us. Dr. Celeste Williams, who is the Medical Director of Circulatory Support Device Program, and also Medical Director for Heart Transplantation. And debating in front of her would be Dr. Hassan, who is Surgical Director of the Heart and Lung Transplant Programs. And there was already some tactics that he applied today by coming at the last minute, so to stress us out a little bit.
Right.
And so how he's going to try to game the system to win the argument. And just please be mindful of your pages and your cell phone, if you can put them on vibrate or on silent so that they do not interrupt the presenters. Celeste, thank you so much.
Thank you, Marwan. To VAD or to transplant? That is the question. Heart failure is a major epidemic in the United States. It claims over 55,000 lives per year, 4,700 lives per month, 977 lives per week, and by the end of this lecture, 5 people will have died from heart failure. Today, I'm asking you to keep an open mind to the different treatment strategies available, in particular, LVADs. Heart failure is a major and growing concern in the United States. Over 6 million patients have this disease, and it's commonly a disease of the elderly. It's people who are greater than 65 years of age. And it's the most common hospital DRG in the Medicare population. Now, this disease costs a lot. It's a very huge burden on our economic system. And the main driver of costs are the recurrent hospitalizations. And if we look at the hospitalizations over the last several decades, they continue to rise. And currently, we're at 1.1 million hospitalizations per year. And if we look at the 30-day readmission rate, it's up to 24.9%. Now, this is very important because each subsequent hospitalization for heart failure increases one's mortality. So a hospitalization is a very important predictor of one's survival. And when we look at heart failure a little bit closer, you know, it has a mortality rate similar or greater to an aggressive cancer like pancreatic cancer or lung cancer. And if we look at class 4 heart failure patients who are treated with medical therapy, some studies show the mortality risk as high as 60 to 94%. So people are dying from this disease. You know, our cornerstone therapy are to use ACE inhibitor, beta blockers, aldosterone antagonists, and for some patients, they'll qualify for BiV pacers. Sometimes we need to revascularize the patient or even consider valvular surgeries. But what do we do when our patients are still symptomatic despite optimal medical therapy? And what we mean is maybe they're hypotensive when you try to titrate up the beta blocker, or maybe they have recurrent hospitalizations. We have treatment strategies available, though there's not a lot of them. So today we're going to talk about the treatment strategies for advanced heart failure. We have inotropes, dobutamine or milrinone. We have transplantation. We have LVADs, which can be used as a bridge to transplantation, meaning that we use this device so the patient can actually live to their transplant. And it really makes a transplant candidate better. The average wait time in Michigan right now is around 7 months, so a lot of times people will not live unless you VAD them. And we have destination therapy, which will be the treatment option for that patient. Palliative care is considered, and it should be considered more often because most patients will go towards this treatment strategy. It's very important to have palliative care doctors on your team so we can figure out what patients want with their end-of-life issues. So let's talk about inotropes. They are not good. Anytime you put a patient on inotropes, their survival is dismal. The mean survival is around 3.4 months, and the 1-year survival is around 6%. So if you have to place a person on milrinone or dobutamine in order to get them out of the hospital, you have to think of something else like VAD or transplant. We can talk about transplantation. We know that that's the treatment of choice, but it's really limited by available suitable donors. and it could be really fatal waiting for a heart. This is a graph of the ISLT registry looking at the number of transplants over the last several decades. And the green is North America. And what you can see as the number of transplants have plateaued over the last several decades is around 2,100 transplants per year. But if we look at the population who's most advanced, there's about 5.8 million patients who have advanced heart failure. About 40% of those patients will have a normal systolic function, so that leaves us with around 3.5 million people. Of that, 5% will have class 4 symptoms, so we're down to 174,000 patients. We transplant about 2,100 a year, so what are we going to do with the residual class 4 patients, the 171,000 patients who need advanced therapies? Because transplant is just not an option for everyone. So the purpose of the VAD is to restore normal hemodynamics and end organ blood flow. And we have to remember that VADs just didn't come up in the 80s. In 1964, Lyndon B. Johnson pushed for the development of an artificial heart program, and the goal was to insert a man-made heart into a human by the end of the decade. In 1966, DeBakey performed the first successful Lvad, and this woman actually lived for 1 year. It was extracorporeal device, and of course it was pulsatile. The first device to be implanted as bridge to transplantation was in 1969 by Cooley. The patient actually survived for 3 days with this artificial heart and 36 hours more after being transplanted. In 1982, DeVries was the first to implant a total artificial heart called the Jarvik 7, and it was actually implanted into a Utah dentist, Dr. Barney Clark, and this was really the first VAD that was implanted as destination therapy because this gentleman was considered too sick to have a transplant. He lived for 112 days, but the device was complicated by thrombotic episodes and infection. And now we're in the era of cyclosporin, and that's going to change the outcomes of heart transplants. So the development of the circulatory support devices became dormant until the 90s. This is a picture of Barney Clark, Dr. Clark, who was our first total artificial heart patient, and he lived for 112 days. There was a lot of media around this. So Rematch Trial was a landmark trial that actually compared conventional medical therapy to Lvad therapy in patients who were not candidates for transplant. So they were destination therapy candidates. It looked at 129 patients who had class 4 heart failure, and it was randomized into 2 arms, Lvad group and medical therapy group. And what they found is at a year, 52% of the patients with Lvads were alive versus 25% in the medical arm. And this was the trial which really, it was a landmark trial that that FDA, this device became FDA approved as destination therapy, the Heartmate XVE. This is a picture of the Heartmate XVE. It's a first generation pump. It's pulsatile. There's an inflow cannula in the, I don't know how this pointer works, but, oh, sorry. Okay, there's an inflow cannula in the LV apex, and there's connected to the pump, and then there's an outflow cannula to the aorta. There's a drive line which exits the right upper quadrant, and from there the patient is connected to a power source, or to the controller. Thank you. Thanks. A controller, which is a computer which controls the pump and gives the patients the alarms. And from there, the patient has to be connected to some type of power source, whether that's batteries or AC current. This device, the patient, of course, cannot be submerged in water, and you can't have an MRI with this device. Now, the mean survival was around 1 year, but this device was really complicated with, again, infections, mechanical failures, and thrombosis. So when we go to the second generation device, this is called the Heartmate 2 device. Once again, inflow cannula into the LV apex. Then you have the device here, which is an axial continuous flow pump, and outflow graft into the aorta. There's a drive line which exits the right upper quadrant, connected again to the controller, and the patient at all times has to be connected to some sort of power source. This device is smaller, is quieter, is more durable. There's only one moving part, and the expected survival is 5 to 10 years. Our longest VAD patient now is like 4.5 years here at Henry Ford. So the Heartmate 2 trial, there is BTT approval for this device in 2008 and for destination therapy in 2010. And over here we have the Heartmate device. It's a third generation device, magnetically levitated, a little bit smaller, and this is a centrifugal pump. And this device was FDA approved for bridge to transplantation in 2012. And this is the closer pictures of these devices, looking at the axial flow pump and the propeller, impeller, and just kind of looking at these devices a little closer. So when we look at the outcomes of the Heartmate 2 pump, this is the bridge to transplantation trial. At 6 months, 79% of the patients were either transplanted, recovered, or were on ongoing support. And this is the survival of the Heartmate device, which was FDA approved in 2012. At 6 months, 94% of the patients were alive in the HVAD group versus 90% in the control group. Now, as time has gone on, more patients have VADs prior to transplantation. And this is very important to organ allocation because VADs automatically are 1B on the wait list, and they have 30 days of 1A time up to the discretion of the clinician. So this is very important. It's getting more difficult to be transplanted when we have so many VADs. 1Bs are not often transplanted. Nowadays, you see more 1As being transplanted. And status 2 patients barely have a chance. This is the survival curve of the Heartmate 2 destination trial. At 1 year, 68% of the patients with the Heartmate 2, the continuous flow pump, were alive versus 55% with the pulsatile pump. What's important to note on this is that the DT trial is actually superimposed on the Rematch Trial survival curve, and you can see that there's not a lot of difference in the 1 year survival, and this is a 10-year difference in study. We have better patient management, but what it lets you know is there's an intrinsic deficit of the pump itself. It's not patient selection, it's not necessarily how we manage the patient, but the device itself had limitations. So the continuous flow pumps have shown to be superior. This is another graph of the Intermax data, which is our registry for FDA-approved devices, looking at patients who've been implanted over the last several years. And what you can see as the time goes on, the survival has improved. And once again, that's secondary to patient selection, where we better manage the patients, our surgeons are better, so it just it makes sense that the survival has improved. So not only do we have survival benefit with these pumps, the patients also have been shown to have improvement in their neurocognitive function, as well as their 6-minute walk tests. Patients have been shown to walk, in the Heartmate 2 trial, they've been shown to walk greater than 200 meters after the VAD was placed. So we have patients are getting smarter and they're getting stronger. Also, we have seen improvement in the quality of life shown by the KCCQ score, the clinical summary score. Patients feel that they're doing much better. Most patients move into NYHA class 1 and 2 after the VAD. So there's a lot of improvement: survival, quality of life, functionality. So this pump has really shown great benefits to the heart failure population. Now, anytime you have a device, you'll have to think of, there's going to be adverse events. There's going to be things that we need to improve on. And the main problems with the pump is, the stroke rate, bleeding, right heart failure. But what I'd like you to pay attention to is that the stroke rate, the bleeding rates, and the right heart failure is significantly less than the pulsatile flow pump. So we have made great improvements with just changing technology. So yeah, there still needs to be more improvement, but there's been a significant improvement. And when we look at the clinical trial versus post-approval study of the Heartmate 2, we see there's even a greater reduction in stroke, both ischemic and hemorrhagic, as well as RV failure. And that can be attributed to, we have now guidelines how to anticoagulate these patients. We have guidelines on how to control their blood pressures. This is the VAD activity in the U.S. You can see it's grown exponentially. And the main treatment strategy that we see for these VADs are destination therapy, meaning this is going to be the treatment option lifelong. And we probably all heard in the news about Vice President Cheney getting an LVAD and then moving on to a transplant about a year and a half later. And this really raises ethical question. You know, when is someone too old to transplant? This is such a scarce commodity. When should we consider just VADing these people and not necessarily transplanting them? So who are appropriate candidates for destination therapy VADs? Well, these people should have advanced heart failure. Their EF should be less than 25%. They should be on optimal medical management, so they should be on their ACE inhibitor, beta blockers, aldosterone antagonists, if they can tolerate. If their QRS is greater than 120, they should have a BiV pacer. These patients should have class 3, 4 heart failure symptoms, so they should be symptomatic at rest or with minimal activity. You can also use the metabolic stress test looking at the peak VO2 or the 6-minute walk to determine whether or not they're walking less than 300 meters. So, you know, when you have these type of patients that come in to see you, you have to consider, are they VAD or transplant candidates? Now, you know, some patients will be candidates for transplant, but what about the patients who are not eligible? What about the patients who are too old, the patients who are 75 years of age? Or they're too big. Maybe their BMI is 39 and the cutoff here at Henry Ford is 35. Maybe they have a high PVR and they can't have a VAD straight because they would develop RV failure post-VAD or post-transplant. What if they had a recent malignancy? You know, for LVADs, you can have LVAD if the survival is thought to be at least 2 years. But for transplants, if it's not a local cancer, you have to be cancer-free for 5 years prior to getting a transplant. So the VAD is a very nice option for people who have cancers, who are in remission but still have heart failure. HIV is another condition that we could possibly VAD, renal insufficiency or hepatic insufficiency. So, you know, there's a lot of things that we just can't, you know, we can't transplant everyone. Okay. So in order to determine who is at risk of dying, we can use different risk models. There's the Seattle Heart Failure Model, as well as the Heart Failure Survival Score. And we use these to help us determine the timing of considering someone for advanced heart failure therapies. Now, I know VADs cost a lot. And if we look at the cost of VADs over the last several years, they're very expensive. But the good news is that the cost has decreased substantially over the last 4 years. And that's secondary to better patient selection, better devices. We manage the patients better post-operatively. So this graph is looking at VADs versus transplant. Transplants are in the green. We have a long way to go, but there has been significant improvement, and so we cannot forget that. So who are the potential VAD patients? Like, okay, so this is kind of a guesstimation. There's about 300 million people in the United States, and about 5.5 have heart failure. The NYHA class 3B and 5 is around 374,000 patients. Of that, 75% will have comorbidities that will exclude them for VADs. So that really leaves us with 93,600 patients who are potential VAD patients. So per this estimation, we should be doing about 30 VADs per 100,000 population. And if we look at the largest metropolitan cities in the United States, how they compare as far as trying to get to that 30 per 100,000, you can see that Houston is at 2 per 100,000, and we're about 1.8, 1.9, Detroit, that's us, per 100,000 population. So we're the second center in the country. No, we're not at 30, but I think we're pretty respectable. So we know heart failure has a very high mortality rate, and we need therapies to reduce it. Heart failure costs the United States a lot of money, and we need to develop strategies to reduce the cost instead of just abandoning therapies. We know these patients have poor quality of life, but with the VAD, we have seen improvement in quality of life, improvement in their functional status, as well as improvement in survival. Cardiac transplant offers the best outcomes, but it's limited to only 2,100 transplants per year, and everyone's not a transplant candidate. VADs have not provided the outcomes patients and clinicians desire until now. Thank you.
So, again, thank you, Celeste, for taking quite a bit of time to cover some of my area. As Dr. Williams mentioned, we have a heart failure epidemic across the world, and especially in the Western world. 5.3 million Americans are affected. The cost, direct and indirect cost, is up to $34.8 billion a year, which is substantial, especially in this era where we're kind of half bankrupt on the healthcare side. Since Celeste gave us such a beautiful presentation about heart failure and the incidence, I'm just going to give a snapshot of about the importance of this disease process. It is the leading cause of death in the Western world, pretty much. And but there is a person among every 100 people in the United States over the age of 65 who suffer from heart failure. And once the diagnosis is coined, it's estimated, regardless what the class is, that there is about 50% mortality over the course of 5 years. And when you look at the size of the pandemic or the epidemic between 79 and 98, there has been an increase of the death rate by 135% related to heart failure. Essentially, with this pandemic, a very valid solution came up, and it's certainly not VAD. It developed over the course of the 20th century, starting with the inception of the 20th century. Tons of research, and many, many people put their names on the map. This all culminated with the first human-to-human heart transplantation in Cape Town on December 3rd of 1967. This sparked up a lot of interest in heart transplantation. Many transplants happened. The immunosuppressive therapy that we had at the time was limited to steroids and azathioprine. And people were given tons of doses, which resulted in poor healing, and most patients ended up dying from infections. So with that, with the poor outcome, there was a huge amount of discouragement. And in 1982, when cyclosporine came and the concept of triple therapy with lower doses came on board, that sparked up the interest. This is a slide that Dr. Williams put up a little earlier. It's from the ISHLT database with reported cases. And you can see immediately after the early 1980s, when cyclosporine came on board, the number of heart transplantations exploded, got up to about 2,200 in the early part of the 1990s, and stayed up there, as she adequately pointed out, based on the limitation of the available hearts for transplantation. So essentially, to look at the SRTR data, just to kind of have a hint of the waiting list activity, you can see that about 3,000 patients, about between 2,000 to 3,000 active patients are added to the list on a yearly basis. And you see the years going from 98 to 2010. In reality, when you look at the waiting list count at the end of each year, on New Year's Eve of each year, you see the number of active patients who are on the transplant list range anywhere between 1,500 to about 2,000 or so. So I'm not sure where the 100,000s of patients that you're talking about are coming from. Well, it's okay. Essentially, when we look at outcomes of patients who are on the waiting list, you can see that about 10% of the patients die while waiting for an organ transplant. And that definitely points out the deficit of available organs for us. The other 10% are removed from the list for variable reasons. Some of them improve, some of them decide not to have it, some of them get too sick to be transplanted. However, the vast majority, about 80+%, within 36 months are transplanted. And about 10% at the end of 36 months are waiting to be transplanted. And this is not from my pocket, it's the STR database. So the total number of adult hearts that are performed on a yearly basis witnessed a dip in about 2005, 2006. However, it really came back up this past year. 2,200 hearts did take place, or heart transplants did take place in the United States. Looking here at the length of waiting based on the priority status of the patients. For hearts in general, we have 3 priority status points. 1A, 1B are the highest 2, and status 2. There were some changes with the incidence of the number of patients who are 1A or 1B because of the VAD being upon us. And what complicated the situation further is the allocation system changed in 2006, where they allowed not just local and regional A and B zones, up to 1,500-mile zone. When a donor becomes available, they screen them for 1A first, and then they go to 1B across the whole area before they came back to a local status 2, which means nowadays status 2 patients are rarely, if ever, are transplanted. The only one I remember doing here in the last 4 or 5 years was a lady who got just lucky because she was number 85 on the priority for the offer, but the donor family insisted on going before a certain hour, and we were the closest center, so we took the heart. So that's an issue that definitely needs to be ironed out, because a lot of the VAD patients don't necessarily need to be transplanted as status 1A while on the VAD and have no complications. Essentially, looking at heart transplants, and we'll go over this result some more, but I want you really to remember this number. The 50% survival of heart transplantations is close to 14 years in this day and age. So this is a point we need definitely to remember when we talk about VADs as an alternative to transplant. Looking at the Kaplan-Meier survival curve of heart transplantations as submitted by the ISHLT's website, showing that well over 70% of the patients are alive and well at 7 years. And different colors obviously depict different age group of the recipients. And you can see the lowest one is patients who are over 70. And this is probably one of the main reasons why many transplant centers, including ours, don't transplant patients who are over 70, because they tend to do poorly. And that was the question that Dr. Williams brought up about Dick Cheney getting a heart. In terms of really the money shot for heart transplantation is looking at rehospitalization after transplant. And you can see that freedom from rehospitalization after transplant is about 50% in year 1. And it's about 80% in year 2 and 3. And that holds true also up to year 5. So this is a very solid therapy with wonderful outcome. Yes, it's not a magic solution for the problem. And I always tell the patients when I can send them that we're substituting a very tough disease process that's chronic and deadly with less tough and less deadly chronic disease process, albeit it's not a solution for the issue. But we have some really bright spot in the results. Looking at morbidities that happen as a result of heart transplantation and the immunosuppressive medications that we put the patients on, you see the hypertension is a substantial amount of a problem. Even people who don't have hypertension in the baseline, many of them do develop it. And by about 5 years after transplant, 92% of the patients do suffer from hypertension. When it comes to renal failure, it's a major problem for any transplant, any organ transplantation. So it's the same for the heart, where we see by the end of 10 years, 68% of the patients have some degree of renal failure. However, only 6.1% are on dialysis, and about 3.6 to 4% require renal transplant within the course of that period of time. The other issues that we see are hyperlipidemia and then the new onset diabetes because of the steroids. And the most important factor that we see in terms of leading to mortality in these patients and significant suffering is the development of cardiac allograft vasculopathy, which is a form of chronic rejection for the heart that we cannot overcome no matter what we do to it with immunosuppressive therapy. And you see in the last column, at 10 years, that occurs in about 50% of the patients. Freedom from allograft vasculopathy, the ISHLT had a beautiful slide looking at 2 time periods, between 94 to 2002 and then between 2003 and 2010. The idea of looking at the 2 different time periods with the occurrence of vasculopathy was to just see if we got better with managing these patients and in preventing vasculopathy. Obviously, we did not. The difference, yes, it's statistically significant, but when you look at the number, I'm not sure the difference is of any clinical significance, actually. So we did not do a good job with that over time. When it comes to freedom from severe renal dysfunction, it seems that we got a little bit smarter in the way we handle these patients. And there is some improvement in the freedom from renal failure, although it's still substantial. At 7 years, it does affect about 20% of the patients in the current era. But it's somewhat better than before. Hopefully, it continues to get better with time. The biggest dinger in any transplant, actually, is the development of malignancy. So by the same token, when we lower the immune function of the patient, their chances of developing malignancy become substantial. Over the course of 10 years, as you can see here, about 70% of the patients are free from malignancy. However, 30% of the patients do develop a form of malignancy. Thank God the majority are skin and simple, but there is a substantial minority that leads to significant mortality and morbidity in this subset of patients, that whether post-transplant lymphoproliferative disorder or other forms of cancers other than that, like lung cancer and kidney cancer and so on. So definitely that's a major problem, and as long as we have the widespread immunosuppressive therapy that we shoot the entire immune system down with it, this stuff is going to continue to happen until we get something better to do. Looking at freedom from malignancy in general across the board, you see that the majority of all malignancies account for about 50%, but skin still like the most important. But the biggest killer really is the non-skin and non-lymphoma. That's the biggest killer for our subset of patients. This is just a cute SRTR slide that depicts what killed these patients at the end of the transplant journey. And we see the malignancy, organ failure, cardiovascular lesions, infections, and graft failure. Here, it's a little bit more sophisticated. I'm sorry for the degree of busyness of this slide, but it really represents the issues in a clear way. And you can see that malignancy other, which is down in this column, essentially accounts for a substantial percentage of death. If you add it to the lymphoma too, it will be quite a bit big in patients over 15 years. So the number one cause of death is malignancy in our patients, and then number 2 will be vasculopathy and then graft failure and so on from other causes. Again, looking at 2 eras for mortality after heart transplantation, you see in reality when we look at the different colors that depict the different pathologies, we see we got a little bit better with handling the vasculopathy issues, but we did not do any good otherwise. All the numbers otherwise from the 2 eras between 94 to 2001 and then 2002 to 2011, our incidence of problems that lead to mortality is about the same. We haven't improved with our management too much. Now the key issue with heart transplantations and its real value for the patient is looking at the functional status of surviving recipients after transplantation. And you see that a substantial percentage, that's about 40% of the patients, have 100% of their functionality with no limitation of function whatsoever. And if you take combined people who have 90% of their functionality up to 100% of their functionality, it's close to 70 to 80% of the patients have wonderful sustained relief, even up to 3 years and beyond after transplantation. So this is where the value is, because although it's not a 100% normal existence, it does provide the closest option to normal existence that we have at this point in time. So nobody is on a leash, which is a great thing. The other issue, also looking at employment status and functionality, but it's nothing personal. Looking at functionality and employment status of the patients, 1/3 of the patients will be back to some form of work. There is about 1/3 who retire, and I'm sure a lot of these sub-patients who retire are the folks who, in general, are close to their 60th birthday or something of this nature, and they get sick, they get transplanted, and they don't feel up to going back to work. And there is a substantial 1/3 who become totally not working. So now, at the end of the day, albeit this existence is not necessarily very normal, that shows my age. I grew up watching this. So you know, although the existence of our $6 million man is not normal, however, it's really a robust existence. And I think there is a lot of value in heart transplantations. As I'm not saying the sole option. I mean, VADs are really good and helpful to get people to transplant. But I don't think we are at a point where we can say VADs are instead of transplant. So thank you.
We first started transplanting in 1967. Okay. And it's 2012. You're only transplanting 2,100 patients per year. And their survival is around 13, 14 years, median survival. You still haven't explained to me, what are you going to do with those other patients who are not transplant candidates? You know, we have to have an option. You know, what is a life worth to you? So what are you going to do with those other patients? Okay, my statistics that I had, that I read, I got from reputable journals. What are you going to do with that 100,000 patients that need some other options? Everyone's not going to be a transplant candidate. Okay, that's one of my, that's not really my main question for you.
Okay.
Right, right. Also, you know, you're not giving us enough time. You know, transplants have been in the works for almost 41 years. VADs, really since 2003, we had the Heartmate XVE FDA approved. You know, our cost of the VAD has gone down significantly. Our survival has improved. Patients are becoming more functional. And for the time period that the VAD has been available, there's been great progress. So I think it's really important that if we have that type of strides the next 10 years, you know, we may be up to your survival for transplant. Okay? And I don't think transplants are benign at all. You know, you said that the readmission rates are pretty, you know, looking at the ISO2 registry, you said the readmission rates are not that bad or from the registry. But if you look at the readmission rates for LVADs versus transplants, actually LVADs have more readmissions. However, the costs of the transplant readmissions are more. They have more problems with rejection. They have more endomyocardial biopsies, and their length of stay when they're readmitted are much longer than VAD patients. So, you know, it's not you know, there's costs associated, and it's not a benign type of therapy. There's a lot of complications associated with it.
Great few points that you made, and definitely from my standpoint, I am not saying that, you know, VADs don't have a place to do. There is definitely a progress, but to get back to your point, VADs were born in 1964.
Well,
so, and the claim was that they're going to be wonderful within 10 years. Right. So we're about almost 50 years later, we're still struggling with the concept. So essentially, Dr. Williams, you have a point, okay, which definitely I'm not going to argue against. But I truly think we should have changed the title of this talk just based on my data, that for end-stage heart failure patients, if you really can't transplant, why VAD? That is the true question.
Okay.
Yeah, that's the way I look at it, at least based on what we have. And I'm sure I convinced everybody. I have no doubt in my head. You know, I decided yesterday I wasn't going to argue with you against you too much because, number one, you're really good at what you do, you know. And I do have to work with you every day. and at the end of the day, you know, you are the one who sends me the patients I transplant. So I'll be jobless if I tick you off today. Okay. I'm going to try not to do this.
That's good.
And most of all, the most important point, you really are tough nut to crack. You know? So I'm going to try that. I'm going to try just for the sake of honesty. And, you know, if this is what transplants offers you, why in the hell do you want that?
Oh.
You know?
That's low.
So essentially, in a very convenient way, last week I was looking at a couple of things, and here comes the 5th Intermax annual report, got published, and I went out and looked at it. And looking at it, I just kind of selected a few things. Obviously, it supports my point. Looking at the survival rate and death of all comers with your favorite continuous flow devices. I eliminated the pulsatile stuff. This ain't good. But the continuous stuff is the best thing we have at this point in time. And you see that the 50% survival rate is well less than 4 years as compared to 14 years with transplant. I don't think 10 years are pocket change for a lot of these patients. So that's number one thing. Looking at the adult primary continuous flow numbers that were reported, you can see that freedom from stroke over time. Okay, it's beautiful in the first month only, and then starts coming downhill from there. So at 36 months, almost 20% of the patients suffer some embolic stroke or some bleeding stroke phenomenon. That's not an insignificant issue. And obviously, we thought that when we move out of the pulsatile flow, we're going to have an improvement. I think this is probably some worsening in comparison to the old Heartmate. And it relates to other factors related to the pump and the artificial continuous flow situation where people walk pulseless. It's like without a soul. So the other issue also, when we look at the Intermax data, you have freedom from infection. Yes, nowadays, the old things that we used to bump into, pump infections and all these bad things, are not common to happen. But you look, for God's sake, look at this driveline infection. It's substantial. At about 33 months, almost 40% of the patients have it, which is definitely not an insignificant issue. It contributes to a lot of complications. When we look at major events, stuff that really lead to suffering in the VAD patients, it's usually infection, bleeding, especially GI bleeding and brain bleed, device malfunction, stroke, or death. Over time, if you take all these major events together over time, really, I don't know. I'm not sure what you're talking about. It's bad. So,
BiVADs, you're going to include them?
Well, I have to. You're proposing it as alternative therapy. I mean, my heart transplant is a BiVAD. You take the whole heart out, put 2 VADs in, right? So, you know, I'm just comparing notes. That's about it.
But Dr. Nemeh, where's the data about post-transplant freedom from infection, rejection?
I just showed you the data, but you're probably not remembering too well. I have one tough lady to deal with. I don't need 2, right? So, and then, when we look at other major event incidents, you look at the freedom from events over time. You know, over the course of a few years, it's becoming really substantial. Now, since you may mention the BiVAD business, okay, I separated them out for you, okay? This is the course for the BiVAD. And these are real patients. How much life is worth to you, right? I mean, these are real patients. So look how terrible their outcome is. Okay, so essentially your VAD is good enough for a ventricle that's relatively compensated on the right, and you can just boost the left side with it. Now, when you take the LVAD alone, the curve ain't much prettier even when we separated it. I mean, it's somewhat better, but not a lot. And then looking at quality of life. Oh, my God. You know, it's not that great, right? I mean, we have, yes, it's a major improvement. Pre-VAD, about 50% of the patients have some limitations, looking at the European Quality of Life Questionnaire. And then you see at 12 months and 6 months and 3 months, you know, still about 30% of the patients have substantial effect on their quality of life. For usual activities, it's the same story. At 12 months, 50% of the patients have significant limitations. And the summary of the Intermax report essentially showing that there has been a massive improvement in VAD management and the outcomes in VAD in comparison to the miserable stuff that we used to have before 2006. But still we have issues. There is positive improvement, but we're not there yet. That's the whole point. And, you know, looking essentially at a very nice paper that came out. And I'm going to rush through these things. I don't want to bore you guys too much. But there was a paper that just got published earlier this month. Okay. Essentially, we're looking at the occurrence of heart transplant and LVAD. There is a sharp rise in the VADs, but they did not definitely change the outcomes. And looking at unadjusted mortality, the VAD, you can see Celeste point, it really dropped very sharply, but it's still quite a bit higher than mortality with transplantation. And then when it comes to the cost, which is the most important point at the end of the day, it's really a big burden on our system. There is no question about it. From a cost effectiveness standpoint, the VAD measured by their quality effect on life, essentially they're still not cost effective. They're far away from the point of cost effectiveness. So, and you see here, most heart transplant patients go home versus a lot of VAD patients end up going to nursing homes and rehabs and other facilities. I'm sure that will improve with time. And, you know, I'm just gonna conclude at this point in time. There is ample of room for improvement, I think. They're here to stay. They're good, but and I'm not voting for this guy. Yeah.
All right. Okay. So we're going to go through a couple questions, and hopefully we were able to answer these questions throughout our debate. And the first question, everyone has a controller. Okay. Class 4 heart failure patients have a mortality rate similar to an aggressive cancer, for example, pancreatic cancer. True or false? Does everyone know how to use this automatic system? Okay. True or false? Do we have any music? No.
Jeopardy.
Okay. All right. Okay. I think that's good. The answer is true. Great. That's exactly right. The mortality, 1-year mortality risk could be as high as 94%. The number of heart transplantations is limited by a shortage of suitable recipients. True or false? You can answer this one. Okay. Oh my gosh. What? Why would someone say true?
I convinced them.
We don't have enough donors. We don't have enough donors. We have recipients. Remember, we have 100,000 people that need something. Okay, I think it's maybe a double nine. Okay, a patient with biventricular heart failure should have, these are the options. And this, we're assuming this patient has advanced heart failures and needs some type of treatment. LVAD, transplant, LVAD and transplant, neither. So someone with both right and left ventricular heart failure, what type of options do they have? Do you guys understand the question? Kind of confusing. All right. Should be transplant, because both their right side and left side doesn't work. The LVAD is just a left ventricular assist device. It has nothing to do with the right ventricle. If the right ventricle doesn't work, It can't get blood over to the left side, and the LVAD is useless. So this person has to be transplanted. Yeah. Or, you know. All right. Right. A patient with a recent history of breast cancer, but she is in remission. She had cancer about a year ago. What's her treatment option? LVAD, transplant, LVAD and transplant, neither.
Treatment option for heart failure, right?
For heart failure, assuming that she has advanced heart failure, assuming that she needs something. Oh, very good. She is not a candidate for transplant because she has a recent history of cancer. You have to have 5 years, be cancer-free in order to get a transplant, so that's good. Some people are still not. Okay, a patient with end-stage renal disease on hemodialysis. They need advanced therapies. Would you LVAD this person, transplant a person, LVAD and transplant? Neither. No, it's only not. That's right, right. Yeah. Well, no, you can't in this question. Can't. Yeah, this patient is not a candidate for dual organs. Okay. Can you take it back?
Yeah, actually, the last one would take.
So the answer is neither. Assuming this patient is not a candidate for a heart kidney, transplant wouldn't be an option. And as far as LVAD, we do not want patients on dialysis having a VAD. They already have problems with infections, and that's not the kind of quality of life. So they do very poorly if they're being dialyzed on a VAD. Their mortality is quite high. So that's actually an exclusion for LVAD, long-term dialysis. A patient with poor social support, should you LVAD them, transplant them, LVAD and transplant them? Neither. Okay. Great. Yes, you need adequate support to have an LVAD. You need a family to help take care of you and to help support you, get you to your office visit, so that's great. A patient with active cigarette smoking smokes 2 packs a day. And assuming everything is okay, the lungs are okay. Can we LVAD this patient, transplant the patient, LVAD and transplant? Neither. Okay. I hate to say this, but we can actually LVAD this patient. We just put them on a behavioral contract and they continue to smoke. They may never get a transplant, but we can, if their lungs are okay, we can actually VAD these patients. That's pretty bad, huh? A patient who is 74. A patient who is a 74-year-old man with ischemic heart disease. 74. What will you do with this patient?
Depends on who he is.
Does he have? Well, it might be as well. Depends. Really should be LVAD. We go up to 75 for our LVAD program. We would consider older people if they are pristine, whatever that means. You know,
good body around the bad heart.
Right. All right. A patient who is a 28-year-old man who's 5'9", 230 pounds, blood type O. He has a history of myocarditis. What will you do? 5'9", 230, blood type O. You can answer this one, Nemeh. BMI is 34.
32.3.
Okay. Okay. VAD, transplant, VAD and transplant. All the answers are right.
Yep.
But he's going to wait a longer time because it's a big O. But it depends on how sick he is. You can do any of these strategies.
And there is
Except neither.
There is a subset of patients when they're VADed who improve and can be VADed as a bridge to recovery in this entity.
Right.
Although I haven't seen many personally.
No, but there's young patients with small hearts. Okay. A 68-year-old man looks younger than his stated age, is being referred for consideration of a heart transplant. He has non-ischemic cardiomyopathy with an EF of 15%. The patient had a stroke in the past and is confined to a wheelchair. He has short-term memory deficit, but his wife is dedicated and takes care of him 24 hours a day, 7 days a week. He is currently on milrinone, and he has class 4 heart failure symptoms. Right, right, okay. What will Dr. Nemeh recommend? List patient as a status 1B immediately. Lvad as destination therapy. Palliative care consult. Remember, he's a surgeon.
Well, since I don't think a lot, I'll go with 1.
Right. Okay. Excellent. Palliative care for this person. Remember, for LVAD patients, we want them to be independent. We want them to go back to independent living, enjoy their families. You don't want them confined to someone having to take care of them in a wheelchair. So this is actually a palliative care. The majority of the patients with advanced heart failure will have palliative care consults. We only can help a very small percentage of the people with advanced heart failure. So the answer is palliative care. Why would someone transplant them, though? Seriously. Okay.
That's besides me.
Okay. After an LVAD surgery, the patient will not be able to do one of the following: exercise, swim, travel, self-care. You guys better get this one right, because the program depends on it. Good.
Awesome.
Yes. You can't swim. Exactly. Good.
But why?
Huh? Okay. What is the average 1-year survival of the LVAD patient? Okay, this data was from the last Intermax. You have the most updated when I turn, So it's still very close to what Dr. Nemeh said. What is the average 1-year survival of the LVAD patient, both BTT and DT included together? Okay. %. Good. Very good. 82%. It's like 80 now, but that's 82%. Yes. For our total together is like 83 point something %. Yeah, we're like right at Intermax, last Intermax. Okay, this is, I think, the last question. 23-year-old woman with new onset heart failure with symptoms less than 3 months. Her EF is 20%. She has NYHA class 4 heart failure symptoms. Her heart is normal size on echo. The cause of her heart failure is thought to be idiopathic. Patient is not responding to standard cardiac medications with 5 hospitalizations over the last 3 months. Not a good sign. Patient is hypotensive at baseline. She is extremely symptomatic, requiring inotropic support to perfuse end organs. Workup for advanced heart failure therapies is initiated. Patient medically qualifies for both VAD and transplant or transplant. So what will we do with this patient? Will we and this is right now. Will we VAD her, transplant her, palliative care, or watch and pray? So what do you guys want to do with this patient? Okay. This patient needs to be VADed. She has, she's hypotensive at baseline. She has 5 hospitalizations in a short amount of time. She's a new onset of symptoms. I mean, this woman is sick. That you don't wait for a transplant for someone like this. You get them triaged to VADing, and then if you need to do a transplant afterwards. But she needs to be VADed. Why would someone send her to palliative care? I don't know. Okay.
A lot of.
I know.
No,
Okay.
but seriously, a lot of the outside physicians end up sending these patients palliative care as the only option.
Right.
One observation that is interesting is that I would say the transplant appears to be superior. But there's one benefit that I think that VADs have over the rest of the organs for replacement. Because the primary function you need for the heart to do is pump, you just have to build a better pump, especially if it can be internal, then you leave all the infections out and just worry about the stroke. All the other organs, because of all the metabolic functions, are so far from that.
I love your comment, but they have a high risk of infection too.
What
The LVAD. They have driveline infections. Now, the new, no.
You're saying if it's implantable.
Oh, totally. Oh, absolutely. If they could come up with a transcutaneous, they are working on it right now.
But I've been hearing this for the last 10 years.
Yeah, I have too.
It will happen.
How are you able to justify insurance-wise and everything else, and this sounds a little bit morbid then, people who are dying effectively and then extending their life 2 years knowing that they only have 2 years, especially if Lvad was bridge and now it's destination treatment, how are you able to justify that? Because once your therapy stops, they're going to die. You know, I'm thinking about for renal failure, we might give someone a kidney, you may say, well, Dr. Denny, the half-life of the ECD kidney may be 5 years, but after once they go back on dialysis, they don't necessarily die. Once your LVAD stops working, they're going to die. So how are you able to, in this medical climate, pay $200-something thousand to extend someone to 2 years, and then that's it as destination therapy? How does that work?
It's challenging. We have to, each VAD we do, we have to have an approval. They have to meet specific criteria. If you don't meet those EF less than 25%, peak VO2 less than 14, if you don't meet those certain criteria, Medicare will not pay for the device. So, it's challenging, but right now we are getting reimbursed, but the Medicare reimbursement is a lot less than the private insurers. And that's going to be a problem going forward because in order to keep your program viable, you need to make a profit. So it's going to be, with dealing with Medicaid and Medicare, the reimbursement is not as robust as a private insurer. So it is challenging.
Why are you saying ethically? Why spend the money?
I think
Why?
both. I think
Really?
philosophically
Well,
one, and
medically, it has almost quadruples the survival because with the continuous flow devices from like not even 20% at 1 year, it's like 70-80% at 1 year now. So it quadruples your survival at 1 year. So that's the rationale. Now we have to work on the cost effectiveness, and we can replace that. So even if an LVAD fails, as long as it's not because of RV failure, you can actually do a
Replace is not good.
Yeah, well, the outcome, though, just for people to understand, the outcome from replacement of an LVAD is half as good as the LVAD initial placement. The biggest issue here, it is palliative therapy at the end of the day. We're not at a point where it's an absolute great option. It is wonderful for what we have. The support that we're getting essentially from the insurers, the reason they're not kind of pulling the plug on us, is the fact that they recognize that with time we have been improving a lot, and there is a lot of hope for what's coming up in the future for this. So, this is a form, we look at cancer therapy, it's the same story. Jeff, go ahead.
No, wait, she's
I'm
been
sorry.
waiting, yeah.
Once you place the VAD, they can only be status 1A for 30 days, because to me that would seem you would maybe hold off placing one because you would hope for a transplant. It doesn't make sense to me why you would do that.
You want to answer?
Go ahead.
Okay, so for all VADs, they're status 1B. Just to have a VAD makes you a 1B. You get 30 days of 1A time, and it's up to the discretion of the physician or the clinician. If you don't have a VAD and you're not on inotropes, you're going to be a status 2. So you'll never get a heart at a status 2. So it actually changes the organ allocation. We have now more 1Bs because a lot of people have, like we showed, 43% of the people waiting for transplants have VADs. So we have a lot of 1Bs. So it's harder to get a transplant now as a 1B.
But you have people sometimes playing a game where you have somebody that's a 1A and they hold off putting that VAD in until they absolutely need it just to get.
It's not playing
It's
games.
not actually what it is. It's essentially for specific subset of patients whom we think have high risk from the VAD intervention. We try to hold off, hoping for a transplant. It's not gaming the system. It's trying to see, because it is literally like a throw in the dark. You either hit it or you don't. So sometimes we put patients on the list as a 1A with a swan in the ICU and a mirrorinone drip, because we know if we go in, this is the 4th time going into their chest, or there's a lot of concern about the function of the RV, or some other issues that make this surgery particularly dangerous for them. That subset of patients will benefit if we can get them to transplant. However, if we feel that they're starting to slip in between our hands, once they go to close to cardiogenic shock, then we have to give in and put the VAD in. But this is really a very funny issue, because what's happening now with the VADs that are upon us, the allocation system became very hard for a subset of patients. Some people who have, for example, the dilated cardiomyopathies who are not very, very bad, but they go on the heart transplant list as status 2. They're out of luck. So that's problematic. And even the VADs, which is funny, the majority of the VAD that are being transplanted now, they don't get transplanted within the 1A status. Either the allocated 1A month, or when they get VAD complication with thrombus or something else, and then we boost them up to 1A, and then they get transplanted. So the majority of our VADs have, either driveline infection or something, or within the allocated 1 month time.
Jeff, one more. Jeff had it, Dr. Morgan.
Just one point related to Jason's question is for patients who are not transplant candidates and you're evaluating them for ET, VAD, or medical therapy, or nothing, those patients have about 100% mortality for them. And so it's VADs. There are patients who live with VADs for 5, 6, 7 years. It's difficult to determine who's going to have that stroke-related complication or VAD infection or other life-ending problem with their VAD when you first evaluate them. So, for these NYHA class 4 patients who aren't transplant candidates, it drastically increases their life expectancy, as Dr. Kia mentioned. But again, it's difficult to say who's going to have that stroke.
All right, well, I want to thank everybody, and Dr. Williams and Dr. Nemeh.